Hi and welcome to Physiotutors podcast episode 61. In this episode, I will talk to Dutch researcher Corinne Visscher about temporomandibular disorders, abbreviated as TMD. Corinne is a physiotherapist and epidemiologist who has completed her PhD on TMD and has published more than 30 papers on the topic. Next to her research, she is working as an assistant professor at the Academic Center for Dentistry in Amsterdam. Hi, Corinne. Welcome to the podcast.
Thank you.
Corinne, to start out, could you please give us a definition of what TMD is and what it all includes?
TMD, it's an umbrella term for a variety of disorders of the masticatory system. So it includes problems of the temporomandibular joints and also problems from the muscles like the masseter or the temporalis muscle. And patients suffering from these kind of disorders, they usually have pain. Usually they have mild to moderate pain. Or they can have clicking sounds during movements of their jaw. And also muscle movement limitations are often present in these patients.
Okay, and how high is the prevalence of TMD in the general population? How high is the incidence?
The prevalence is somewhere around some 10 to 12% of the population. In these cases, the problems usually are mild. So if you look at the prevalence of treatment need, so the amount of patients who will be searching for a specialist, it's quite lower. It's about 5%. Yeah. And what we know from the literature is that even that 5% of the patients who in fact would have an indication for treatment are not seen by specialists. And so we know that only around 1 to 2% of those patients actually are in the clinics of physical therapists or dentists, for example.
And what about the incidence? So how many people get it per year?
Incidence is around 1 or 2% per year.
Okay. And could you maybe describe a typical TMD patient in terms of age or gender or other characteristics that you see in your clinic?
The typical TMD patient, it's a female. She's around between 20 and 50 years old. Yeah. And she usually suffers from moderate pain or some limitations in movements. But obviously, it's not a disorder which is only present in female patients. Also, males can suffer from these disorders. And when you see these type of disorders in children, you more see problems of clicking sounds, for example, or locking of the joint. And when you see these kind of problems in more aging people, elderly people, it's more related to degenerative disorders. So it depends a bit on what age range you look at, what type of TMD problems you will find.
Yeah, so per age group, it's a different
subtype of TMD.
Yeah. Okay. And talking about risk factors, what are risk factors to get TMD? And I've had a look at your research a little bit. And in one paper, you had a look at hereditary factors. So maybe that is a factor as well in TMD. Can you talk to us about that?
Yeah, the risk factors also are wide. It's not one etiological factor for the presence of TMD. I think we approach the TMD problems from the biopsychosocial model. And in general, I think you can say there's 3 types of risk factors. So the first, it's related mainly to oral behaviors. So we know that behaviors like grinding your teeth or clenching your teeth, which you usually can do during the day, so holding your teeth together. This is an important risk factor for the development of TMD, but also other habits like nail biting or chewing gum, for example, are included there. The second group is related to psychosocial factors. The biggest risk factors there are anxiety and depression. So patients who score high on those kind of risk factors, they have a higher risk to develop an initial TMD, but also when you have a first episode of TMD problems to develop chronic complaints. But also factors like somatization, widespread pain, and catastrophizing thoughts. So also the way you think about the presence of pain influences the development of TMD pain. And then the last one that's more relatively new, that's the genetic factors. So a couple of years ago, I was able to join the Dutch twin register. They have a huge amount of twins connected to their organization. And every couple of years, those twins, they receive some questionnaires on medical problems. And I was able to include some questions on TMD and neck pain. And from that study, we could see that, in fact, also genetics, heritability, plays a role in the development of TMD. And then from other studies, which is not my own studies, but more the basic science studies, you can see that probably it relates to the specific genes coding for neurotransmitters and pain transmission. And if you have a more unfavorable genotype, package of genes, you are more vulnerable to develop complaints, and especially chronic complaints.
So it might be more related, the genes might be more related to chronic pain in general and not so much to TMD. And I can also see how my psychological state really relates to TMD because, if I'm stressed or anxious, I'm probably inclined to clench my teeth or move my jaw a lot. So I can see the connection there for sure. And if we move on and we look at our diagnostic process, the first thing we always do as physiotherapists is screening. If someone is referred to or is not referred to us by the general practitioner, for example, are there any general or are there any specific red flags to the jaw area besides the generic red flags that we always ask?
Well, if you screen for TMD, I think it's there's three variables you need to pay attention to. Obviously, there's pain in the orofacial region. That's the most obvious indicator for a TMD problem, but important to ask when a patient reports that kind of pain, because orofacial pain can have many causes. So to screen, to have a first screening whether this can originate from the masticatory system is to also ask about the location of that pain, but also whether the pain increases on function, on using your system, like chewing or opening wide and things like that. If that's positive, it's quite likely it's a TMD problem. So, and then I think you ask also for the yellow flags in these kind of patients, or the red flags, perhaps
flags
even.
first, and then maybe yellow flags second.
Well, red flags are not really described for these kind of patients. It's not like there's one thing you for sure have to exclude before you classify these problems as TMD. But I would say if you have a patient with orofacial pain and the patient describes the pain as really severe, it's not typical for TMD. Also, when they wake up from this pain, it's not typical for TMD. And also when the pain increases over time constantly, it's also really not typical for TMD. So these kind of descriptions of orofacial pain, you should refer to perhaps first a home physician, but then to a specialist. The yellow flags we use, it more relates to more the specification whether the patient is a patient for primary care or more multidisciplinary treatment. So if you should screen in our field for the psychosocial problems. So when there is anxiety or depression, you can screen with short questionnaires. It's not too difficult. But if depression and anxiety seem to be present, also that's a patient, it's better off in multidisciplinary care.
Okay, and let's say we ruled out the red flags we discussed, or the more general red flags, and we have a patient in front of us that we can treat. How would your diagnostic process look like?
Yeah, well, it doesn't differ much from the general process we use in physical therapy, of course. Where I work at the Academic Center of Dentistry in Amsterdam, we usually see the more complex patients. So our process is a little bit more expanded than what you would do in primary care. So in our case, we do start before we see the patient already. We send them some questionnaires. So based on those questionnaires, and the questionnaires include questions on the physical complaints they come in for, also other physical complaints they may suffer from, but also the psychosocial questions are included there. So before we see the patient, already we have some idea of whether there are yellow flags we should consider in treatment planning. Then when we see the patient, of course, we start with a proper oral history, asking for location and description of pain, habits, and so on. And then we perform our clinical examination of the masticatory system. This clinical examination, again, it looks like the examination of other joints, shoulders, neck, for example. We usually start with the active movements. So we check whether these movements are within normal range. We also check whether there's sound during those movements. So while performing those movements, you also palpate the joints, because the sounds, you don't always, we say sounds, but you don't always hear them, but you feel them. Yeah. Exactly. And also we perform passive movements, because that tells us a lot whether there's limitations from the muscles which might be tightened or the joint. Palpation of muscles and joint tissue, of course, is used. And then also we apply dynamic and static resistance testing. The latter tests perhaps are not very common for every physical therapist. But in dynamic and static testing, what we do is that we ask the patient to first, we perform the dynamic tests, opening, closing, and protrusion, it's forward movement of the mandible. And during a dynamic test, we apply a light counter resistance. So when the patient opens, we make it a little bit more difficult for the patient, but still they have to open fully. And then we'll ask for pain and the location of that pain. And then we perform the static test of the same movement direction. But in static test, the mandible doesn't move actually. And we apply a really forced resistance as hard as we can until the patient can't do more, which you feel by trembling of the mandible usually. And again, we ask for pain. And the dynamic tests, during dynamic testing, we provoke pain from joint and muscle tissue. And during static testing, actually, we only provoke muscle tissue. So based on the combination of the two, you can figure out when it's positive, when there is any pain, it's already a TMD pain. And then from the combination of the two, you can figure out, is this more a joint pain or a muscle pain? That's what we use.
So it's pretty comparable to the normal physiotherapeutic process.
It's just a joint and muscles, so why not?
So the goal is to figure out, is it more a joint problem or is it more a muscle problem, right?
Yeah.
And do you also do the internal palpation, like with the gloves? And that's a bit of my picture that I have of TMD treatment.
Well, in the diagnostics, we don't actually anymore. We did that in the past, but from studies, there's quite some studies on validity of testing in the region of TMD. And we know that especially the palpation intraorally and then the deeper part of the masseter muscle, it's painful anyway
for sure.
Also in healthy persons. So it doesn't discriminate much. So we don't do it anymore for diagnostics. But these kind of techniques we do use for treatment of patients.
Okay.
Yeah.
Also pretty similar to trigger points. I feel like if you look at reliability of trigger point palpation, there's also a lot of discussion going on if it's reliable or valid or not.
Yeah, exactly.
And do you have any, because Physiotutors started with orthopedic special testing, are there any special tests that you use in your diagnostic process other than those static and dynamic tests?
Well, perhaps it's not part of the more general examination of the standard examination we perform, but as physical therapists, sometimes we do a little bit more. So we do use joint play testing of the joint. So traction and especially translation techniques of the joint can be quite informative. Especially when a patient suffers from a disc displacement. So in the joint we have this disc and it can be displaced forward. And if it doesn't pop back on movement, on opening, then the patient experiences opening limitations. And this you can also feel when you perform translation techniques of the joint. You can also feel that there's not much translation possible. And you can provoke the type of problem the patient comes in for. So it helps in confirmation of a disc displacement without reduction. That's how we call this.
Okay.
So that's a special technique.
Yeah, interesting. And do you use any special questionnaires in your process?
So from before we have our intake, they receive a big questionnaire. Well, I would not advise a general physical therapist to use such a huge questionnaire in every patient. But I think what is important, one of the really shorter screening questionnaires, it's the PHQ-4. Yeah. It's 4 questions on the patient health questionnaire, 2 on anxiety and 2 on depression. And it's really quick, easy method to screen for those yellow flags. And this is also a validated questionnaire used in the medical field widely internationally. So this is one I would really advise. For the TMD problem, we also have questionnaires where you can ask patients to fill this in. It's the jaw function limitation questionnaire. And you could use this because then patients can score what type of oral habits they have. I mentioned a few already, but there's many more. Yeah. And it can help you also figuring out later what kind of habits you need to work with this patient to improve on. Yeah.
Like grinding your teeth at night, or chewing gum regularly, stuff like that, I guess.
Stuff like that, but also for example, persons holding the telephone between their ear and their shoulder, or it can also be open questions. I also have had a patient who was a carpenter, and then he had this problem. I didn't understand why he had these problems which did not improve, and he didn't grind, he didn't clench and so on. But then later on I discovered he was holding the nails he needed for his work in his mouth the whole day, every day. And once we discovered that and changed that into something else, his problems resolved quickly.
That's a nice story.
So sometimes you really have to search for the etiology in your patient.
Okay, great. Hey, and in an earlier episode of our podcast, we talked to Sarah Michiels, who talked about tinnitus and its relation to TMD. So I was wondering, is there also evidence of a relation between TMD and headache?
Yeah, sure. Quite strong evidence, actually. So there's quite some evidence on the primary headaches, migraine and tension type headache. And both you see a lot in TMD patients. So many patients suffer from headaches. And what is very interesting is that we also have done these kind of studies in our department. Even though the prevalence of tension type headache is highest in our TMD, is higher as compared to migraine, it's not much higher as what you see in the general population. So then there's not a strong association between TMD and tension type headache. But the prevalence of migraine is twice as high in TMD patients as compared to the general population. Dus there really is something going on why our patients also have migraine. And from a study of a colleague of mine, Hedwig van der Meer, this is her topic. We now know that bruxism, so clenching and grinding your teeth, it's not only a risk factor for TMD, but it also is a risk factor for migraine. And that's the connection probably between the two. So if you have bruxism, you are more likely to develop both TMD and migraine. So that's a very interesting connection between the two.
Yeah. Is there a good way to figure out if I am clenching or grinding my teeth at night? Besides asking my partner, maybe?
Exactly, that's the quickest and quite valid way to but she or he, I don't know, but can only check, of course, for grinding, because that's what you hear, but clenching, also a partner would not know. Well, you have devices like GrindCare.
Okay.
So it's EMG kind of device you can put on your cheeks. So this is something you could do during the night to check whether a patient grinds or clenches. It's less commonly used during the day. But already if you just ask your patient to check this out, to pay attention to daytime clenching more often, many patients will at first tell you, I don't think I'm doing this, but if I ask them and to pay attention, often they will come back a next visit and then they will report that they now know they clench a lot. So it's also paying attention is already helping.
Yeah. I think my girlfriend is more complaining about snoring, but that's a different story.
That's a different story.
Hey, and if we move on and we look at posture and the head and neck position, is this related or is this a factor to get TMD?
Well, it's not a factor to develop a TMD. This is something which was thought a couple of decades ago when we still were more the biomechanical thinking. Then posture was supposed to be a very important factor in developing TMD. We have done quite some studies. I've done something in my PhD also on posture, but also other research groups have studied posture. And we cannot find any association between poor posture and higher risk on TMD. Still, there are studies showing that if you improve posture in patients, it is a useful way of treating your patients. But probably the mechanism then it's not a biomechanical mechanism in the way that it has a direct influence on the TMD, but I think it then works if you improve posture, you also improve muscle tension, relaxation, and so on. And I think that's the way how it does positively influence TMD complaints. So you can use it in your treatment, but there's no evidence to call it an etiological factor for TMD.
Yeah, it's funny that you say that because it's really similar to again general physio. In the past, we thought that posture is really important and it has a strong relationship with the development of pain, but research doesn't show that link. But then yet still sometimes changing posture, or if people keep having or keep going into a posture that provokes their pain, then changing posture can actually help them in the treatment. So I think it's pretty similar again. And say if someone has or if someone has TMD and he comes to your practice, what is the cause of TMD in general? And do we know something about positive or negative prognostic factors for recovery?
Well, I think the cause of TMD in general, it relates to the factors we already discussed. So the oral habits are a big cause. The psychosocial factors really influence your risk of developing more chronic complaints. So that's an important part. And also in the prognostic factors, I think also there the psychological factors play an important role. If you score high in those, well, prognosis is poor or poorer. And you should include it in your treatment plan. I also think you can also see it from another way around. Like what I mentioned, TMD has many subtypes. And when I see patients, and it's a patient with the subtype of limitation of movement, especially when it's a muscle limitation of movement, then I think, well, that's an easy patient because those kind of patients I can treat. Usually, I can help them quite fast. When it's joint related, the movement limitation, so the disc which is replaced and is stuck and in the way. It will take more time. Okay. But still, prognosis is really good. So in that case, I will treat patients somewhere between 6 weeks and 3 months. And then usually the limitations are resolved.
And that's like a treatment per week or 2 treatments per week?
Yeah, well, it's when it's like for the muscle limitation, well, a treatment a week is usually enough. Yeah. But we also give our patients many exercises they can do at home. So we will see them once a week usually. And then also, of course, do some stretching of the masticatory system. There also, for example, we do use the intraoral techniques where we do direct stretching of the masseter tissue. So with your thumb inside, you can perform this stretching. But also passive opening, that's the type of techniques we can use. And we also teach our patients to do that themselves. So important in this kind of treatments is also the involvement of the patient. When it's a disc displacement without reduction, still we usually see them once a week, and later on in the treatment we see them perhaps even less often. Yeah. And again, we will ask our patients to do a lot of home exercises, which may be 2 or 3 times a day, always short, but it may be 2 or 3 times a day that they do some exercises at home. Yeah. Yeah, and pain complaints, when they have pain complaints, well, when it's a simple patient with only a local TMD problem, no yellow flags, still the prognosis is quite good, especially also when I understand the etiology of this patient. So when it's clenching, I will give them some massage, intraoral massage techniques, which can diminish the pain quite fast, but it's only symptom treatment. Yeah. But when I understand the etiology, we will also try to change that behavior. I explain them what is a good resting posture. We can use myofeedback, for example, also to show the patients when they are relaxed and when they use their muscles perhaps too much. So this can help them to change their habits. And also those kind of patients are treated usually quite fast. But of course, we also have this group of chronic pain patients with many more problems, or who have seen already a couple of physical therapists or have had a dental treatment. And then after all these trials, they come to us, and then usually also prognosis is worse. Then it's more difficult to treat them.
Yeah, so we moved already into treatment, which is great, because that would have been my next question. So, we talked about behavioral change. So some people are clenching their teeth or are doing a lot of movements with their mouth that are keeping or that prevents them from getting better. Then you are doing massage techniques or stretching techniques with the jaw, and give them home exercises. Is there also a place for dry needling, for example? Do people dry needling the muscles in the mouth?
Well, dry needling is something which is used in the field. I don't use it. It's not my specialty, so I didn't have any training in that, so it's not something I apply. But I know dry needling is used in the field, and also I know that it's sometimes in patients it is successful. So I'm not against or opposed to dry needling, and I think it's something also which depends on the patient what type of treatment they would prefer. So I think there's a place for dry needling, but it's not a technique which I use myself.
Okay, and if it's a joint problem, or like you mentioned, the meniscus basically that is located there is out of place, do you perform any manipulation or mobilization techniques? Yeah.
Well, I think when it's we call it, in the diagnosis, it's called an anterior disc displacement without reduction. Yeah. So it's the disc which is in front and it doesn't pop back on opening. And in this situation, you have to understand in what stage the patient is. So when this disc displacement without reduction is there only for a couple of days or 2 weeks at the most, an orofacial physical therapist can try to manipulate the disc. So we can apply a technique in which we grab the mandible, we hold the mandible, we use a combination of traction, forward translation, and opening rotation. And by that manipulation technique, you can try to move the condyle below the anterior disc, and if that succeeds, well, you hear it. You hear it pop. Yeah. You can open the mouth suddenly much further. And then you place the condyle together with the disc, you place it back in position. And this is a technique which is a quick success, but it's only successful in patients who have the situation only for a short period. And usually it's a trauma patient. So patients who have had a force against their jaw, or they fell with their bike on the street, for example. Those kind of patients you can help quickly. What we do see more often, it's the type of patient in which the joint, the disc is already clicking for a really long time, and then it's locking more and more often. And then they come in this situation that more and more often they're not able to... You're checking it out already.
I'm checking if
do you have a click?
I think I do, yeah.
Well, it's not a big problem in most cases, but it can develop towards this disc displacement without reduction. And if it's this more process-like, then it's not useful anymore to try to place the disc back in its original position. So what we then do, I always call this plan B. Then we can use techniques which are more mobilization kind of techniques, in which you help move the disc forward more fastly, as it would do if you do not apply any physical techniques. So you help the patients go through this period of limitation and pain, usually. And by these kind of mobilization, mainly translation techniques and passive opening and stretching, you can help the patient to resolve normal mobility. And if mobility is resolved, usually thereafter the pain also gets less.
Okay. Okay, so we talked quite a bit about treatment, and if we move on, and I've read a couple of your papers, what is the research, or what kind of research are you focused on at the moment? So what is the area that is really interesting or hot at the moment?
I think two things. I work together with two orofacial physical therapists. The main focus of Hedwig it's on headache and TMD. The main focus of Annemarie van der Wal, which is the other one I'm working with at ACTA, she studies tinnitus and TMD a lot. So she worked together with Sarah Michiels, which you also have interviewed before. And together we have a grant for another research we are now performing. And this is a study, it's more a qualitative type of study. And this is a study where we describe the journey patients usually make in this field. And what we see is that especially patients with chronic complaints, before they are in the office of the right specialist, they, in many cases, have seen many specialists already. So they go from one specialist to the next, to the next, to the next. And that's a very disappointing way for these patients. So what we try to do is that we are now interviewing these type of patients, and we are trying to figure out how we can find criteria on how to, in a more early stage of their problems, how we can screen for criteria which can help those patients and also their care providers, of course, to more quickly decide what specialist in the field of orofacial pain is the right specialist for this patient. So that's a more qualitative type of study. And this problem that patients see many specialists and have a disappointing way of going through our care system, this is something you see everywhere. So I know also in Sweden, I work together with a group of researchers, and they have the same problem and they do the same type of research. And also in the United States, this is something which is really described, that patients, are missed quite often and have a very disappointing journey throughout our care system.
Yeah, we had a podcast, I think, it's almost a year ago, with Jack March, who is specialized in rheumatology, and it's basically same story that he was telling us as well, that sometimes it takes more than 10 years until we really figure out the diagnosis of someone who has a rheumatoid disease. So I think maybe this podcast can help our colleagues to be more aware of TMD disorders. So, and it's also leading towards my last question that I have. How can listeners learn more about TMD, and what are maybe things that we discussed today that a normal physio can apply in practice tomorrow?
Well, it's a wide last question, I think. But so, how can listeners learn more about TMD? I think I would at least guide them towards the website of the diagnostic criteria for TMD. So, if you just Google DC TMD, it's not too difficult to find.
We'll put a link in the
I can give you the link.
Anyways,
And this is a website where you can find a lot of information on the assessment of TMD and also the related type of assessments we talked about here. On this website, there's also videos on how to perform the standard clinical examination. So it's really useful for everybody who wants to know a little bit more on how to perform this. I think what is also important is that in the Netherlands, we are lucky to have 2 master programs in which physical therapists can specialize in this field. So then you can specialize towards an orofacial physical therapist. That's unique in the world. We are the only country who has this kind of specialization. Well, in the United States, you have you can classify for a special name. It's called a PTBCCT, the physical therapist. Well, it's a cranial cervical physical therapist. That's it. The difference is that in the Netherlands, we have this master training, which is really a 3-year training. I think that's a beautiful training for people interested in this field. So I think those are some important ways of getting more information and perhaps even go do your specialization in this field.
Okay, and so that's if you want to dig deeper and if you want to gain more knowledge. And if we look at maybe the general physio listener out there, what would be a tip for you regarding TMD, or how could they apply knowledge that they have gained from this podcast tomorrow in practice?
Well, I think it's a good thing already if PTs ask a little bit more often about problems in the orofacial region. So the 3 things which are important there is ask, do you have any orofacial pain? What is the location of that pain? And does it increase on function, on using your system? And if all 3 is yes, is positive for orofacial, for TMD, then it helps when physical therapists recognize and also explain to those patients that this is something you can get help for. Because many patients don't even know you can get help for these kind of problems. When it's really mild and a patient tells you, well, it's the type of pain. I wake up, for example, in the morning with some tension in my cheeks. You can ask about habits. And of course, everybody can give them some advices on relaxation of the face, your jaw, your neck. That can already help patients. And in case you think, well, this is the type of problem the patient needs a little bit more help with. Well, in the Netherlands, we have the direct care. You can send all our patients directly also to the orofacial physical therapists who are specialized in this field. And I think that's a quick way to help our patients to find more care for these kind of problems. And also, it's the other way how we can help our patients is also to tell them that they can also discuss this with their dentist, because in some cases it's more the dentist who can help them. So the patient especially is grinding. The orofacial physical therapist, we can't do much because we can't change grinding. But then the dentist, for example, can make an oral appliance which prevents at least tooth wear, but also can improve some pain complaints you have from grinding. So that's also something we can do. So I think in the primary care, screening for it's important. Giving counseling and advices on habits, that's an important first thing every physical therapist can also do. And, well, refer the patient quickly to an orofacial physical therapist or dentist is also helpful to help these patients find the right care.
Okay, great stuff. And looking at the list of my questions, I don't have any questions left. So is there anything that you would like to add, or if you feel like we've left something out?
Well, I realized halfway that I did forget one thing when you ask about the headaches. We talked about migraine and tension type headache. There's also secondary headaches. And one of the secondary headaches which are described is a headache directly attributed to a TMD. And this is the type of headache which is also often missed. Mm-hmm. And it's the type of headache that resembles the tension type headache.
Okay.
So I think that many patients who think have a tension type headache might in fact have a secondary headache related to a TMD. Mm-hmm. And if that's the case, the treatment of that headache is completely different. Yeah, because treatment of a tension type headache is more medical treatment, medication. Yeah. Whereas when you have a secondary headache related to a TMD, you should see a care provider who can treat your TMD problems. And then if that would be resolved, also the headache will disappear. And how can you screen, how can you check, how can you screen whether this headache is a secondary headache due to a TMD? When patients have a headache which is moderate, which is in the region of the temporalis area, and this headache is, they also have a TMD, and this headache has developed in the same time period of the TMD, and you perform a clinical examination of the masticatory system and the headache increases, well, then you know for sure it's a secondary headache due to a TMD. Yeah. So I think that's also something where physical therapists also in the general field can be aware of, and hopefully we detect more of those type of headaches then.
Yeah, pretty similar to the cervicogenic headache type.
Yeah. But the mechanism, the thinking, the classification type is the same.
Exactly. And at last, how can people find you or reach you if they have any further questions?
Well, I think the quickest way is to go to the website of ACTA. We can also put it in the podcast, I think. For sure. There we have, I work at the Clinic of Orofacial Pain and Dysfunction. And so if if physical therapists, for example, want to refer patients to that clinic, you can find the information there. And I can provide you my email address to contact me directly. So that's no problem.
If you want to share that,
that's okay.
Okay, with this being said, I would like to say, Corinne, thanks so much for your time and also for sharing your knowledge. And thanks a lot for everyone listening to this podcast episode. And to access the transcript and additional resources, make sure to sign up for a free Physiotutors membership on physiotutors.com and benefit from more useful physio content. If you enjoyed this episode, hit the subscribe button or follow our podcast on Spotify or Apple Podcasts, and consider leaving a review if you really enjoyed it. And with this being said, this was Kai for Physiotutors, and I'll see you in the next episode. Bye.